Just to, in light of this presentation, I would like to share this two clinical scenario with regard decision-making choice mainly. So the first case was a lady admitted recently. She's 76 years old lady, admitted with lateral Stemi. And this lady, she has background of lateral Stemi. At the end of the, I think on 20th of December, she presented with bifurcation disease. I'm sorry, I wasn't able to get the video on. So she had bifurcation disease, the proximal LAD diagonal disease. She ended by 2 stents, Zay and Sierra. And immediately after discharge, after 1 week, she developed PR bleedings. And at the time of bleeding, she has CT angiogram, which she did not show any active bleeding, but it does show that she had diverticular disease. Her GB changed her ticagrelor to clopidogrel monotherapy. And unfortunately, she readmitted after 2 weeks with stent thrombosis. She had 2 episodes of sustained VT. She treated only by balloon angioplasty, and her initial troponin was 1 to 2 second troponin was 8,500. Her hemoglobin was 87, and her hemoglobin during the prior admission was 137. So the question really with regard prolongation or switching antiplatelet therapy in this lady. So I would like us to share this case with you mainly for decision making. Dr. Egred, would you like to make any comment on this case?
Sorry, how long after the initial presentation did the patient come back?
So the first presentation was 20 on December, and the second presentation was on 9 of January. So it's really around nearly 2 weeks, 3 weeks.
Okay. And in terms of bifurcation stenting, what strategy was employed over here?
So initially was professional stent to stent LAD, and then thereafter she compromised her diagonal, so she ended by a second stent as a killer to proximal LAD diagonal 1.
Okay. So it's a culotte stenting, is it?
Yes.
Okay, fine. The first thing is, as we know, the more the number of stents, the more the higher risk of stent thrombosis, isn't it? And this is a very good example of that anyway. But the problem here is more important is in bifurcation stenting, you've stopped the antiplatelet agent and you've just left it on clopidogrel monotherapy. The evidence of clopidogrel monotherapy is not very good, unfortunately. At least there is some data with ticagrelor monotherapy, but with clopidogrel monotherapy in a bifurcation stenting, this is something that is bound to happen, isn't it? Especially if there is, as we know, there's a non-responder rate with clopidogrel also. So in this particular situation, I just think there were reasons why they did it, but there are few issues over here that could have increased the risk of stent thrombosis in this particular situation.
Thank you, Dr. Raja. And Dr. Abdallah or Nadir, any comment on this case?
It is a difficult situation, and we are facing this from time to time, especially in elderly. But as my colleague mentioned, there is no place for clopidogrel monotherapy. On the other side, also ticagrelor monotherapy might also increase the risk of bleeding. So it is really, you weigh the risk and benefit and take it from there. It's a very difficult situation. We wish we never get into this situation, but it is there, and there is no right answer for this question. However, we have to take the risk and risk of bleeding and the benefit of prevention of stent thrombosis. But it is a very difficult situation.
Thank you, Dr. Abdullah. I think that's exactly what we faced with. I think this was really difficult situation at that time. So we were unable to start any tirofiban or any other strong antithrombotic burden during the PCI, given this lady, she had very low hemoglobin. And at the same time, we ended by, she had stent thrombosis in just like very short period. So we continued as monotherapy, ticagrelor, and I shared this case just to see exactly if someone had different opinion. The second case also, The 66-year-old gentleman, type 2 diabetes, and he is on chemotherapy for active adenocarcinoma. He had liver mets on palliative therapy. He admitted with anterior Stemi on 22nd of December, and again he had the same strategies. He had 2 stents. He had called the stent was Resolute Onyx. On 26, after just 2 days from admission, he admitted to stroke ward with a possibility of query TIA. However, there is no clear thrombus or clear infarction on the CT scan, but it's thought to be query might be MITS. So 3 weeks time, on 11th of January, readmitted with breathlessness, and his CTBA confirmed that he had pulmonary embolism with multiple visceral infarct in his spleen and his livers. So again, I thought this is really difficult question with regard to antiplatelet therapy. Shall we switch this patient from double antiplatelet therapy to single antiplatelet therapy, given now he had ongoing bleeding, he had ongoing cancer, he had on palliative chemotherapy, or shall we, if any benefit from starting this patient on NOAC with double antiplatelet therapy? Dr. Raja, would you like to make any comment on this case? Someone with
again in this particular case, I'm again a bit surprised, because normally in these situations, especially in the STEMI situation, again I would like to keep things simple and try not to employ a double stent strategy. At least do a POBA rather than a double stent strategy. And in this particular case, we know the prognosis is quite poor with some of the metastatic adenocarcinoma of the pancreas. So the thing you would like to do in this particular case, especially if it's a palliative angioplasty or stenting, is try to keep it as simple as possible to help get out of the situation. And then again, like I said, once you do this, then the risk of thrombosis is quite high, unfortunately. And in someone in metastatic CA, we know that the risk of thrombosis goes up even more, basically. So I think that's the problem over here. What I would do in this particular, because of the multiple Ps now, unfortunately, you will need to put this patient on an anticoagulant. And what I generally tend to do in these situations is I'll at least leave them for 4 to 6 weeks on an antiplatelet. And there is evidence with clopidogrel most of the time in this particular situation. So probably apixaban and clopidogrel is what I may have gone for this particular situation. Unfortunately, because of the LAD diagonal bifurcation stenting, it's going to be quite a tricky one in terms of how long would you leave the clopidogrel on for, whether it's 3 months or 6 months. It's quite tricky again. So I don't think I have the right answer for this particular situation.
Thank you very much, Dr. Raja. Does anyone in the panel, would you like to comment? Dr. Ahmed Ali, Sulaiman, or Dr. Safa, or Dr. Abdurrahman Jamil?
Thank you. Hi, this is Dr. Ahmed Sulaiman. How are you? Ahmed Ali.
Hi, Dr. Ahmed.
Yes, I mean, I think my previous colleague reiterated the main concepts. Though we do a lot of primary angioplasties, it's very important to know the surgical background and if the patient will need any procedure soon, or somebody like this patient with cancer. And so we have to know the background. And again, yes, I like keep it simple when you're doing a patient with very high risk of bleeding or multiple comorbidities that might need surgical intervention. So always keep the procedure simple. Avoid doing complex procedures. Definitely a lot for a bifurcation seems too much for such a patient, especially that these patients have guarded prognosis overall because of their cancer. So you don't want to get into complex procedures that have little survival benefit, I think, if any. For the last patient if patients need, in general, if they need an anticoagulation, like your patient's multiple PEs, I'll use a DOAC or NOAC. Here in Sudan, the only one available is rivaroxaban at this point. And I usually de-escalate from ticagrelor to Plavix. So I rarely give triple therapy. I would go for double therapy. I might go for triple therapy for the first week if I have to, but generally, if they're beyond the first week, I go for rivaroxaban because it's the one available here. I understand the use of apixaban being a safer one regarding GI bleeding, but I go for NOAC and clopidogrel. I de-escalate from ticagrelor to clopidogrel and put them on double therapy. I don't think the question of how long going to keep the patient on DAPT, or because this patient, I think survival is limited by the cancer rather than the cardiovascular disease. I don't think 6 months versus 1 year will be an issue. This patient prognosis seems to be not so good with all these metastatic complications. But these are great cases, and I thank you. But again, I tell my fellows, though we do primary angioplasty, we need to know the background of the patient. Is there any surgical procedure that's going to happen soon? Does the patient has cancer or malignancy that is urgent? They need to have a procedure soon. Have they bled recently, or they sometimes have an active bleeding? Because the last thing you want to do is put a stent in somebody who's active bleeding. So because sometimes you streptokinase and the patient is bleeding, and then you put a stent in and you're kind of stuck there. So yes, we do primary angioplasty. We're going to keep our metrics, our time, door to balloon time, but we also need to listen to the patient, gather as much information as possible, especially if there are scheduled for any procedure, especially for malignant disease that cannot wait, and any suspicion of bleeding. That's still quite important for our cardiology fellows to know about. Thank you for giving me time.
I think this is very important facts actually about delve into the background of the patient and whether he's going to have an operation. And I think it's a very, very important question that a lot of us as registrars miss that when we get a referral about a patient who's got a Stemi. The first thing we want to look at the ECGs and then coming back. But a lot of information, the more you ask, the more information that you get. And the other thing is what I've noticed that I'm not an expert, but the anterior Stemi, and he had stents to his LAD diagonal as a keylock procedure. I'm more inclined toward opening the artery first and think about complex PCI later, because number one, it's time consuming. Number two, your aim is just to open the artery and then think about things. And then also it allows you to gather more information about the patient. So I don't know what the panel take on this.
I totally agree, Nadir, with what you say. I think it's very important as registrars or fellows that you get as much information as possible from the patient. And most of these patients are communicating at that time, so I don't see any reason why we shouldn't. And in some of our centers, for instance, in UK, we have all electronic records, so it's quite easy. Once you go and delve into it, you know what's going on. So I think that is very important. And the first and important thing is, as soon as you get flow down the artery, then you can relax and then make a decision regarding what type of stenting strategy you would like to carry out in each particular patient. I don't think there's any rush once you pour by it and you get TIMI3 flow. I think that is the most important thing in these patients.
Okay, thank you very much, Dr. Raja and Dr. Ahmed Ali Sulaiman. It was a fantastic point you made.